Welcome to This Just In, the show bringing you the latest advancements in healthcare, strategy, innovation, and public policy. And now, for the fastest voice in healthcare, here's your host, Justin Barnes.
Thank you for tuning in. Welcome to This Just In. I'm your host, Justin Barnes. In these segments, I'll bring the latest advances in healthcare, strategy, innovation, and public policy. As always, we're broadcasting from the This Just In studios on the Business Radio X network as well as Healthcare Now radio network. For this episode, my 258th episode, we're very fortunate to have two healthcare pioneers and healthcare leading authors, Dr. John Halamka and Paul Cerrato. Welcome back to the show, gentlemen.
Thank you.
And thanks so much.
It's great to have you guys back. I think it's been, actually, John's my most frequent guest, as I brought up on our last show, which is great. But I think it's been 2 years since you guys have been on the show. Do you know that?
Yeah,
wow. I sometimes say that, 2021 was the longest decade of my life.
Exactly. Well, actually, I think that's a very good point. Actually, we did hymns. I think we were at hymns 21 together, but since we recorded a show about the book, it's been a couple of years. But I think we did record together at hymns 21. It hasn't been quite, but 2 years for the book. So very excited. This is your sixth book together. Is that correct?
Yes.
Fantastic. And we're here to discuss the new book, Redefining the Boundaries of Medicine. So before we dive in there, though, John, where are you calling in, my friend?
So in Sherborne, Massachusetts, though lots of travel. So, it's about 5 cities this month. So you never know where I'm going to be.
Wow. And how's our very favorite Unity Farm Sanctuary?
Well, as the weather improves, trail building becomes the next activity. We have 4.5 miles of trails. We'll be adding about another mile of trails this year. So no rest for anyone.
Wow. So people come and actually, so when you say trails for the animals or trails for people to come and hike and walk through, or what's that?
Yeah, so we're open to the public, right? Mm-hmm. And so we are a public benefit organization, and these trails are open for anyone in the public to explore terrain from wetlands to uplands. And we do have the animals a bit separated from the trails so no one's fingers get bitten should they stray too far.
That's terrific. And I love the Unity Farm Sanctuary. I've been supporting it for a while now. And I do, let my audience know, please, guys, it's a great thing to look into. It's a great service. As John brought up in our last show, 3 cows were just chopped off on that day. So, they do a great service for the whole community, the whole Northeast, and I'm sure even farther. How far out do you guys span? I mean, how far do you guys contacted from to help and support, John?
So although we're mostly New England based, it's very common that we're in Kentucky, Ohio, North Carolina. So we have a number of our staff in the Unity Farm, truck and trailer, driving all over the Eastern U.S.
Wow. It's a great service that you guys are doing, you and Kathy. So Paul, where are you calling in from, my friend?
Oh, I'm about an hour north of New York City in a town called Warwick, New York.
Excellent. Beautiful part of the country, I know for sure. Yeah. So I'm excited to have you both back on air to discuss this new book, Redefining the Boundaries of Medicine. But as I mentioned on our last show, for my new listeners, I thought this book was fascinating as it challenges all of us to rethink and reimagine how healthcare is delivered and how we participated in the 21st century. Whether you're a clinician, administrator, digital health innovator, or even a patient, this book has been written it's very easy to understand what's possible in a high-tech, high-touch healthcare system where, thankfully and excitedly, the patient is front and center. So, kudos to that. I know a lot of work went into this. Have you guys been writing this for basically the last couple of years?
Oh, this one took about a year.
Okay. Wow. Yeah, I thought I was surprised. I thought it was going to be a little bit above my head, and no, but the way you guys wrote it, it's for everybody inside and outside of healthcare. If it's not, if you're a patient or just someone who wants to think about care, obviously a lot of us should be patients because we want to start managing our care no matter how old we are. But it's applicable to everyone. It's very understandable. So I do highly recommend, whether you're inside or outside of healthcare to really check this book out. We touched on some really cool components last time, and even some controversial stuff, which is really, really cool. But the book discusses the lack of interdisciplinary care. What are you referring to in that way, and how do you solve this problem?
So we give an example in that particular chapter. LEDs have become ubiquitous. Everybody uses them, and they save lots and lots of energy. They're very cost effective. Mm-hmm. The inventor who came up with the blue light LED forgot to talk to his healthcare buddies, so to speak. And as it turns out, blue light can be quite harmful to people in terms of affecting their wake sleep cycle. So had there been some kind of collaboration between healthcare and materials scientists, chances are that would have been addressed initially, so that we wouldn't have the kinds of insomnia problems that a lot of people get sitting around in blue light.
Fascinating.
Well, and let me give you just a case example. And Justin, I have no privacy of any kind because I was one of the early folks sequenced in the Human Genome Project. So all of my data has been public for 15 years. I have glaucoma. Now, my glaucoma has caused a little bit of visual loss in the left eye. And Mayo Clinic said, that's a little more visual loss than we would expect with run-of-the-mill glaucoma. So actually, let's do an MRI of your orbits in your brain, and then let's have you meet with a neurologist and an ophthalmologist and look at the potential causes of this. And actually, let's have you get a lumbar puncture to look at the pressure of the fluids in your brain to understand if maybe you could be getting some sort of physical compression of a nerve. So it was that multidisciplinary working together that came up with the conclusion, actually, I have glaucoma. It just, it turns out mine is a bit of a variant.
Yeah. No.
Right. So basically what we're saying is that specialists are not speaking to other specialists, and specialists are not speaking enough to primary care docs. The example that comes to my mind, because my background is as a nutritionist, is if you're a GI doc and you want to refer your patient to a nutritionist, that might be a problem if your organization blocks that kind of a communication.
Right.
Recently, the 21st Century Cures Act has forbidden data blocking. So hopefully that kind of barrier will go away.
Yeah, I mean, I think how we actually closed the show last time. You guys are talking about the importance of collaboration, and I think that just goes back into to this component in collaborative care, and obviously you talk about the Cures Act and how we are interoperating in lots of different ways in healthcare, and we're trying to limit, obviously fuel up interoperability and limit any data blocking. So I think it's great, but also just collaborating in general, certainly around patient care. You guys hit that perfectly. So another section is on healthcare misinformation, how widespread it is. How do we address this without alienating patients?
Yeah, that's the issue, not to alienate patients. I think it's important to create an emotional bond with patients. And there's lots of research to support that, which we talk about in the book. But at the same time, we also have to admit that medicine has made a lot of mistakes over the centuries. And the more you take that humble attitude with patients, the more inclined they are to trust you. Mm-hmm. When you come across as a father knows best patriarch, people get turned off by that. But if they see that you and your colleagues are fallible, there's more of an emotional bond that's likely to be created. And once that bond is created, they are more likely to accept contrary ideas, like whether it be smoking is bad for you or whatever. They're more likely to accept advice that they don't want to hear if they already have an emotional bond with you.
Excellent. And this idea of making sure we monitor our algorithms for misinformation, really important. Paul and I recently wrote about the NIST risk management framework, which suggests that AI should be valid, reliable, safe, secure, resilient, accountable, transparent, explainable, interpretable, privacy enhanced, and fair, with harmful bias removed. Because if we are publishing, as Paul suggests, our experience from the 1980s to 2020 on the internet, and then AI in 2023 says, well, I've read the entire internet and here's what you should do, it could do harm.
Excellent point. That's great. Paul, you mentioned something about smoking being bad for you. Where'd you read that?
Yeah, it's just my imagination, right? But believe it or not, there are a lot of people who are still convinced that it's not harmful. And just to digress a little bit, one of the stories that we mentioned in the book is one of the journalists we looked at visited the Flat Earth Society's convention. And believe it or not, there are thousands of people who still believe that the flat Earth is reality. And the journalist's point of view was, it's easy to go in with the attitude, these people are a bunch of idiots, and to send that message. But he didn't. He came in respectful to their beliefs and basically asked subtle questions to get them to think, well, maybe there's not enough evidence to support this. So we can learn from somebody who has that type of humility and respect for other people's beliefs, regardless of how bizarre they might be.
Right. I agree completely. In the book, and this is a big piece for me personally, is you advocate for more emphasis on lifestyle management and certainly less on pharmacotherapy. How, in your opinion, how realistic is that in today's healthcare ecosystem?
John?
Well, it's hard is the answer.
Yeah.
So, Justin, you and I probably didn't work together 25 years ago when I had a body mass index of 32 and weighed 275 pounds.
Right.
And so 25 years ago, my clinician said, you're obese. Oh, shocking. I'm obese. I didn't think of myself as obese. And he said, but don't worry, we're going to give you $700 a month of metabolic poisons. And with, statins and ACE inhibitors and beta blockers, you can eat, keep eating those Big Macs. To which I said, how about this? I have a lifestyle problem, not a medical problem.
Right.
And in 6 months, I lost 100 pounds. And I have been a vegan, strict vegan, since that time. And I've not gained or lost a pound since 25 years ago. And because of that, what does that imply? I am the dream patient of healthcare payers. Because in effect, in 25 years, I basically had no claims.
So true. That's excellent.
Yeah, and just to follow up on that, I think that a lot of docs just don't push hard enough. It's very easy to keep patients happy by saying, well, we'll give you that statin, rather than saying, listen, you want to survive the next 5 years, change your lifestyle. That's not an easy message to deliver, especially if they can go to the next practice and hear their ears tickled by the push for drug therapy. So the example that comes to my mind is diabetes. Oftentimes the road of least resistance is to prescribe metformin, and it's almost given out like candy these days. But there are risks to it. It can cause B12 deficiency, which in turn can cause anemia and dementia. It's rare that the average physician will tell them, yeah, okay, you can take metformin, but keep in mind some of the possible adverse effects, as opposed to changing your diet, seeing the registered dietitian that I recommend. So it's like John says, it's not easy, but it's the best way to go for many patients. Anyway.
Yeah, and I would say by far. I mean, I'm a subscriber to this. About 7 years ago, I went on a journey to lose 30 pounds, just because to get more into my ideal weight. Obviously, save a lot of money in healthcare, and specifically, eat much healthier, have a lot more energy. And this is how I talk to my friends. I mean, my friends who, if anyone, if they're overweight or obese, I bring it up to them very, gently, but persistently, because, I approach it from not only the health aspect, the energy aspect, but also the financial aspect. You are going to spend a lot more in healthcare than I am, as I tell them. I mean, I'll probably 4 to 10x what I spend, you will spend. So yeah. And certainly diabetes is one example, but go ahead. Yeah, please.
So the message has to be gentle but firm.
Yes.
Gentle but firm.
Yep. Very true. So for those just tuning in, we're speaking with authors Paul Cerrato and Dr. John Halamka about their new book, Redefining the Boundaries of Medicine. So let's dive in a little bit. You both with Mayo Clinic. So how is the Mayo Clinic platform addressing the need for unbiased and validated AI algorithms?
Oh, that's John.
Okay, so here's again a challenge.
Yep.
Algorithms depend on training data. And when I describe training data, I use three variables. I say depth, and that's the different kinds of data, structured, unstructured, telemetry, images, genomics, digital pathology. Breadth, the number of patients, and spread, the heterogeneity of those patients. You need people who are tall and short, fat and thin, old and young, right? And so no one organization is going to have enough depth, breadth, and spread to produce algorithms that are generalizable for the entire population. And so you need what we call a distributed data network. Organizations around the world willing to be part of a virtuous ecosystem so that algorithms can be locally tuned. Eric Horvitz, who's the chief scientist of Microsoft, and I were chatting about, there's no algorithm that is going to be developed, let's say, in some urban center and then will work perfectly well in some rural center. It just won't happen. So you better have this virtuous network of data, de-identified, privacy protected, secured, of course.
Yep.
If we're going to develop algorithms and locally tune them to patients in every part of the globe. And so Mayo Clinic Platform has facilitated that model. And so far, we have about 25 million de-identified birth to death records of patients across multiple health systems. Hopefully by the end of 2023, it will be closer to 100 million.
Wow. That's fantastic. What are some of the solutions you guys are working on there at the Mayo Clinic Platform?
Yeah, this is what impresses me. I've been with Mayo for 2 years, and I still am awed by what's going on here. So digital pathology is now becoming a reality at Mayo. Digital endoscopy. I work with a doc named Mike Wallace, who's a gastroenterologist at Mayo, and he's done some really impressive work on what's called CAD, computer-assisted diagnosis of colorectal cancer. And the algorithms really are there to improve the detection of colorectal cancer. So those are two examples. And the third one that jumped out at me was radiology. We're jumping into the field of radiology and speeding up the auto contouring process. Now, what that's about is when a patient has to have radiation therapy, let's say there's a tumor in the neck or the head, the radiation beam obviously you do not want to hit healthy tissue, so they have to map the head so that the beam only hits a specific part where the tumor is.
Yep.
That's a very long, tedious process, and with the help of the Mayo Clinic digital scientists, we've come up with a way to drastically reduce the amount of time it takes to do the auto contouring process. And time is money, so it's working.
And just to add some numbers to what Paul has said, I am a 61-year-old person, so I care a lot about accuracy in colonoscopy.
Yes.
Do you know that across this country, lesions on colonoscopy are missed by humans 20% of the time? But with an algorithm augmenting the human, this Mayo algorithm that Paul described, the miss rate's 3%. So I could contend that 5 years from now, practicing endoscopy without an algorithm will be malpractice.
Wow. That's fascinating. And I completely agree. Wow. So one thing you've been a pioneer, John, in Mayo Clinic, I believe at large, but the hospital at home movement. And you guys have obviously immersed yourself in it, but tell us a lot about that. Tell us a little bit about that. It's a fascinating concept. Obviously, I believe there's a lot of opportunity there, savings, innovation, but what are your thoughts?
So let me tell you a very quick story that puts it in context. So about 15 years ago, my father-in-law was on a camping trip with me in the Sierra in California, and he developed pneumonia. Now, I'm an emergency physician, so we were in a cabin at 9,000 feet in the Sierra, and I said, oh, you just need Q24 injections of ceftriaxone and some oxygen, and you're going to be fine. So I treated him, and he was in his 80s, for community-acquired pneumonia in a cabin in the Sierra for under $500. His outcome was fabulous. And he, of course, sat enjoying birdsong and watching lakes and clouds. I then went to bill the insurance company for the $500 of antibiotics and oxygen. And they said, well, we would have funded a $20,000 ICU stay, but $500 for care in a cabin? Oh, can't do that. So what it illustrates is a whole lot of disease that you can treat really well in a home. That's going to result in, as Paul has suggested, spirituality is better. You're surrounded by family and your pets. You eat your own food. You don't have hospital-acquired infections or falls. And that's what we've done to large scale. Now discharging over 20,000 patients across the U.S. from their living rooms after serious and complex disease has been treated in their home.
Wow. You've discharged 20,000 people?
We have. Now, Mayo Clinic, you have to understand, start small, think big, move fast. We started with one patient and then learned what worked: supply chain, staffing, safety, remote patient monitoring, and then 10, and then 100, and then 1,000.
Yes, no.
And so this model has proven, and we study every patient's entire process to learn from every patient going through advanced care at home. That's the name of the program.
Yep. Love it. Fantastic. So following kind of along this line, you guys have got a new master's degree program, Mayo and Northeastern University. Talk about that a little bit.
Yeah. So John and I are both involved in teaching that. The dean of the program approached me. Actually, I originally approached him and says, well, I wouldn't mind teaching one of the lectures. Mm-hmm. And he says, well, how about doing a whole course? I said, okay, that's great. So he asked me to do a course on data mining and machine learning. So that will involve explaining what we call the AI toolkit, which are all the various modeling techniques, and then going step by step through the various tools that can be used. And then finally, giving them a project in which they create an operational plan to actually put in place an algorithm that would fix some administrative problem or some clinical problem in their hospital. So kind of a real world application of what I'm teaching there in the course.
Wow.
And so, Justin, let me tell you the philosophy here. So as I say, as a 61-year-old person, I look at the next 20 years of my career as mentoring those who will replace me.
Amen.
Mm-hmm. And that is, I don't want to publish more papers. I don't want to seek fame and fortune. I want to make a difference and leave something behind. Yep. And in this teaching, in effect, you take the 40 years of experience and all the things you've ever done wrong, and you make sure those who will replace you have the benefit of your experience.
No, it's fantastic. So what topic are you specifically speaking on, John?
So I get to start with, so here's this whole industry. Where did it come from? What did we learn? A broad overview of healthcare, digital health, and health science, so that there's a context for the rest of the course.
I love it. And my indoctrination was a little different. It was more of just, I was very fortunate, I graduated college, wasn't sure exactly what I want to do the rest of my life. Someone saw I was doing a lot of work in the military and had business and Rotary Club and volunteer work. And they said, come work with us in this health IT industry. And so it was HBO company, McKesson back in the day. It was in the 90s, but that was my indoctrination. And it was, I wish if I'd taken your course, or, if there was a course back then, I would have learned a lot more, but I went pretty quickly on the fly, and it was the best industry by far for me. And I highly recommend people look at not only this course, but certainly health IT, digital health in general. So much opportunity. Healthcare gets bigger every single day. The impact on our personal health gets better every single day if we take it seriously, if we follow some of the best practices. So, I think it's fantastic. Any parting thoughts, John, real quick before we close the show the next minute or so?
Well, just as we've been chatting about, our healthcare ecosystem and innovation are moving so fast.
Mm-hmm.
One of the things you have to make sure of is that we as humans are going to be able to manage the change, kind of a digital Hippocratic oath to do no harm. And so much of what Paul and I are working on is sharing experiences, building coalitions, facilitating education, and ultimately spreading this notion of that digital Hippocratic oath. So those who will replace us will benefit healthcare of the future without causing harm.
I think that's fantastic. You guys are terrific. Thank you, Paul. Thank you, John, for joining me today for this great second show. Everybody, please check out their new book. I think you guys will enjoy it, Redefining the Boundaries of Medicine. And I hope to see you guys certainly at HIMSS in April, HIMSS 23 in April, and if not sooner, maybe at the Vive conference. And thank you to everyone for joining us today. Please tune in weekdays at 2:30 p.m. Eastern, 11:30 a.m. Pacific. As always, you can track me on Twitter at HAT Advisor and use the hashtag #ThisJustinRadio so we can respond to your comments from the show. If you missed any of this episode or want to hear more, all my shows are posted at Apple iTunes, SoundCloud, iHeartRadio, Spreaker, Google Play, and TuneIn, and also some great new content at justinbarnes.com. Thanks, everyone. Have a terrific rest of your day.